We talked a little bit about the different types of capillaries that you'll see in your body. The majority of those are going to be your continuous capillaries. The fenestrated capillaries are going to be commonly seen in areas where you need to have a lot of transfer of materials. Fenestrated, meaning windows. I know on Tuesday I said fenestra, but it's fenetra in French, but just kind of similar word. Just means window. And if you hear fenestrated capillary, just think about a capillary that has openings in it. And you'll find them especially in like the kidneys, intestines, places where you need to have a lot of absorption and transfer of nutrients. And sinusoidal capillaries are going to be in organs where you have a lot of movement of materials, especially in like the liver. You'll see it in places like the spleen, the bone marrow. So you're thinking like a lot of transfer of cells, so high volume in those sinusoidal capillaries. And this is what a capillary looks like. That's muscle tissue. So you have your striations in the muscle. And then capillaries are going to be super narrow. The erythrocyte, which is very tiny, is able to make its way through the capillary. You can also get leukocytes coming through the capillaries as well. And then moving on in terms of the rate of flow in capillaries are going to be very slow. You're going to have blood moving very slow so that they can maximize the amount of transfer and exchange of gases, nutrients, hormones, things like that. Forward, we already talked about that last time. So let's talk about what kind of materials are going to be moving through capillaries and how. So passive diffusion, that's going to be one of the more common ways that materials move through capillaries. Passive diffusion, just think about one of the major things that the capillaries are used for. It's for transferring of gases, right? Oxygen getting transferred, carried through erythrocytes, and then you have oxygen unloading at the peripheral tissues, and then you have the carbon dioxide being brought onto the erythrocyte so that everything can be transferred over to the respiratory circuit so you can have that gas exchange. And that's just going to be through simple passive diffusion. Bulk flow, which we're going to talk about in a little bit, that's going to be how you see movement of materials and fluids in the extracellular space, in the extracellular fluids. Now, in terms of movement of materials, anything that's lipid soluble is just going to get transferred right through the membrane. You don't have to have any sort of special channels for that. It just diffuses directly across, basically down a pressure gradient. Whereas anything that's water soluble, ions, glucose, anything like that is going to have to have some form of water pore or water-filled pore. So openings where you can have those ions getting transferred through. And then plasma protein, albumin. We're going to talk about how albumin is really important in maintaining oncotic pressure. If you don't have any albumin in your system, you're not going to be able to maintain proper fluid balance, and you're going to get basically a shift of fluids into the interstitial space. So we're going to talk about the different variables that come into play in maintaining your fluid balance. And then, if I remember correctly, this is where we closed last time. Those are those water-filled pores. Basically, anything that's water-soluble is going to be able to move through those. Ions, water, you might be able to get glucose moving through those as well. And then lipid-soluble substances will be able to diffuse through the endothelial layer. So you're thinking oxygen, carbon dioxide. You're also thinking things like steroid hormones, right? Because steroid hormones are lipid-soluble. And then plasma proteins, albumin being the most important of your plasma proteins. Those are not going to be able to transfer across the endothelial layer. And if you do transfer certain types of proteins, you're going to have special channels to be able to move those proteins across into the interstitial space. So let's talk about the difference between diffusion and osmosis. This is like basic biology, but albeit basic, it's very important in maintaining your different types of pressures, hydrostatic pressure and oncotic pressure. Now, in terms of diffusion, that's just pretty straightforward. You're just moving right downstream a pressure gradient. You're going from a really high concentration of something, maybe it's solutes, maybe it's water, and then you're basically pushing those substances downstream to a lower pressure gradient. Now, osmosis is going to be different. You're going to go from low to high concentrations. The important thing is the concentrations, the solutes. So if you think about how like water follows solutes, water follows salt, like when you're urinating, if you want to increase urine volume, you'll increase the amount of salt that gets released into the nephrons. And if you want to decrease the amount of solutes, for instance, if you had like aldosterone, if you have aldosterone released, that's going to increase the amount of sodium reabsorption in your nephrons, and then water is obviously going to follow those solutes. So basically, you're kind of moving against a gradient in one regard. You're moving towards a higher concentration of solutes. So we'll talk about how that comes into play in the capillary beds. So in terms of bulk flow, that's going to be really important in maintaining your extracellular fluids, okay? And these are the two major processes, filtration and reabsorption. When you're filtering something out, that's going to be, for instance, like a high pressure scenario where you're filtering from a high pressure space into a lower pressure space. So that's going to be capillary, like the capillary pressure gradient for fluids. And then reabsorption is going to be based off of oncotic pressures, where you have materials in the extracellular space or the interstitial fluids moving back into the vessels through reabsorption. And basically it's going to be dictated by oncotic pressure, which is going to be dictated by the presence of your plasma proteins like albumin. So on the arterial side, you're going to have a high amount of pressure. So that's going to be capillary hydrostatic pressure. So that means you have a lot of pressure in the capillary beds from the arterial side, and then you're going to filter things out of the capillaries at the arterioles. Then as the blood moves further along towards the venous side, then what takes over is going to be oncotic pressure or osmotic pressure, bringing fluids back into the blood, because fluids are going to follow solutes. So if you have any fluid leaving, we call that filtration. If you have fluid coming back in, that's just going to be simple reabsorption. So in other words, the most important thing in the arterial side is going to be filtration. So hydrostatic pressure is going to outweigh osmotic pressures. And then when you start getting into a lower pressure scenario, when you start getting closer to the venules, then you're going to have osmotic pressure outweighing hydrostatic pressure. All right. And then in terms of terminology, your textbook is going to be using blood colloidal osmotic pressure. Just for the sake of simplicity, we're just going to use capillary osmotic pressure. It's a lot easier. So you have capillary hydrostatic pressure, CHP, versus capillary osmotic pressure, or COP. And then the other types of pressures are going to be in your interstitial space. You have hydrostatic and osmotic pressures in your interstitial space as well. So you have interstitial fluid hydrostatic pressure. That's going to be the pressure of the actual, within the venules, in the interstitial space pushing back into the venules. And then you have interstitial osmotic pressure. And that's going to be based off of solutes, in particular your plasma proteins. So capillary hydrostatic pressure, that's going to be greatly determined by your blood pressure. The higher your blood pressure, the higher the capillary hydrostatic pressure. As your heart is pumping and the harder it contracts, the more you're going to have pressure pushing out into the interstitial space. Let me move back here. Then your capillary osmotic pressure, that's going to be dictated by the presence of albumin. That's the most important of all of your plasma proteins when it comes to maintaining fluid balance. Interstitial hydrostatic pressure, that's going to be the pressure from the interstitial space trying to push back into the venules, or the capillary beds that are closer to the venules. And then you have interstitial fluid osmotic pressure. And that's going to be, generally speaking, you're not going to really see albumin in the interstitial space. So it should basically be zero. You're not really going to have much in terms of the interstitial fluid osmotic pressure. So here's just a summary of all that. Capillary hydrostatic pressure, that's blood pressure, right? Your blood pressure is pushing fluids into that interstitial space. Capillary osmotic pressure, bringing fluids back into the vessels due to the presence of albumin and plasma proteins. Now, when it comes to interstitial fluid osmotic pressure, As I mentioned back here, you're really not supposed to have any, right? It's supposed to basically be zero because you're not supposed to have albumin in the interstitial space. However, in cases of inflammation, where you do want to increase vascular permeability for the purposes of getting things like white blood cells into the interstitial space to be able to attack whatever is causing the inflammation. So histamine is going to be released to increase that vascular permeability, in which case you're going to be able to see more fluids entering into the interstitial space. Unless you have that taking place, you're really not going to have much in terms of the oncotic pressure from the interstitial space. Now, you're going to see more filtration than you do see reabsorption. And on average, you're going to see about 10% more filtration than reabsorption. And when we get into the lymphatic system, we'll talk about more detail about lymph, but that's going to be the fluids, the excess amount of fluids that enter into that interstitial space. If you weren't able to clear out the fluids from the interstitial space, 10%, if it starts accumulating, then that's when you start seeing conditions like edema. And so I'm going to show you images from in chapter 21 of conditions like lymphadenopathy, lymphedema in particular. That's going to be where you have a huge buildup of fluid in your tissues, oftentimes caused by either obstruction of lymph nodes and the lymphatic vessels, or could be also secondary to removal of lymph nodes from like the treatment of cancer. So for instance, women that get radical mastectomies, sometimes, well, if they get a radical mastectomy, they're going to get the lymph nodes removed from their axilla. Their axillary lymph nodes are what basically receive fluids from the arms. And so women who have radical mastectomies generally will start getting accumulation of fluids in their arms. They'll usually have to require some form of treatment, whether it's like compression stockings or just massaging out the fluids. So it's a pretty unfortunate consequence of getting a radical mastectomy. So anyways, like I said, filtration in general is going to be about 10% more. And that 10% more is going to be made up of lymph within the lymphatic system. So embedded within all your capillaries are going to be a bunch of lymphatic channels to receive all of the extra fluids that build up. So let's talk about edema, which is just going to be a greater accumulation of fluids than normal. So if you wanted to calculate net filtration, that's the basic equation. You're going to be taking your capillary hydrostatic pressure, your interstitial fluid osmotic pressure, so that's going to be one side, and then you're going to subtract the interstitial fluid hydrostatic pressure as well as the capillary osmotic pressure. So if you had increased capillary hydrostatic pressure, where you had maybe hypertension, a patient that has really high blood pressure, those patients tend to have edema, especially in their lower extremities. They'll have things like pitting edema, where you have different stages of pitting edema. Oftentimes it's going to be either hypertension or it could be due to congestive heart failure, especially right-sided heart failure. If you had right-sided heart failure, you basically have blood accumulating and pooling in your lower extremities, and that's going to result in bilateral edema in your lower appendages. You could also get that from venous obstruction as well. If you had decreased in capillary osmotic pressure, you're also going to see edema. That's going to be secondary to a reduction in albumin in your body. That could be either due to liver failure or it could be due to starvation. If a person's starving to death, they're not getting enough protein in their diet, they're not going to be able to form and produce albumin so that they would be able to maintain a healthy capillary osmotic pressure. And you can also see edema when you have that histamine release. So you can see that in allergic reactions, especially. You'll see histamine release. So yeah, that would also increase vascular permeability, which would result in edema. So long story short, just to summarize over here in the corner, when you think capillary hydrostatic pressure, you're thinking blood pressure. If you're thinking capillary osmotic pressure, you're thinking albumin. So these are different types of edema. That's going to be lower extremities. You guys remember what this is called over here? Ascites, yeah. So that's where you have too much fluid in your peritoneal cavity. And those are the lymph nodes that would be responsible for receiving lymph, the excess amount of fluid that is filtered in your interstitial space. Angioedema, that's going to be edema that you see around the orbits of the eyes. You can also see it in other areas like the hands, groin. You can see swelling of the lips. That's after a serious case of angioedema right there. That's the guy might have eaten something that maybe he was allergic to. Yeah, he might start going to anaphylaxis. Once you start seeing someone swelling, the biggest concern that you have is swelling of the airways too. So if a person starts swelling in the airways, that's why oftentimes people with severe allergies will carry with them epinephrine pens. EpiPens basically help to vasoconstrict, so it can reduce the amount of fluids entering into those areas. And that swelling of the epiglottis. Cool. So let's talk about the control of blood. So now we're going to sort of wrap in both the cardio system and then the vascular system and just kind of tie it all in together. So in terms of control of blood pressure, there's this theory that's been kind of floated around. It's called the metabolic theory of autoregulation. This theory sort of proposes that the major way that your vascular system controls itself is through a balance of carbon dioxide as well as oxygen. So high carbon dioxide would cause vasodilation, low oxygen might cause vasodilation. There's a lot of studies out there that have basically disproven this theory, so it doesn't really hold much weight. So in other words, the maintaining of your hemodynamic system is going to be depending on mostly vasomotor tone. That's going to be the major component. So there's going to be a lot of ways that your body is able to do that, some of which might involve different types of chemicals. So we talked about histamine. Bradykinin is going to be another compound that gets released to increase the inflammatory process. It's effectively doing a similar thing that histamine does. And nitric oxide is another thing that can control blood vessels. Nitric oxide is a vasodilator. Did we talk about angina in this class? We did talk about angina. How do you treat angina? You could treat it with nitroprusside. Nitroprusside is a drug that basically acts the same way as nitric oxide. It helps just to vasodilate. Cool. Let's talk about the neurological components of regulating blood flow and blood pressure. So the medulla oblongata is going to be heavily implicated in sympathetic control. And so what the medulla oblongata helps is regulating blood pressure as well as vasoconstriction versus vasodilation. Now, one thing to keep in mind is that when you see sympathetic activation, you don't necessarily see constriction of all the vessels. There's going to be certain vessels that you want to remain patent, right? If you had vasoconstriction globally, that would be a pretty bad situation. Like, for instance, if you had a sympathetic reaction, you're getting chased by a lion, you don't want the vessels in your heart, your coronary arteries, you don't want them to constrict. You want them to remain dilated. Same thing with your muscular, same thing with the vessels in your muscular system. You don't want those to vasoconstrict. Otherwise, you're not going to get enough blood delivered to those tissues when you're trying to undergo a fight and flight reaction. So other things that we're going to talk about here are the baroreflexes as well as chemoreflexes. So baroreflexes, that's pertaining to changes in pressure. There's a couple areas in your vessels that respond to pressure, one of which is the aortic arch. You also have those in your carotid arteries. And then there's going to be chemoreceptors as well that can detect changes in levels of oxygen, carbon dioxide, and changes in the pH levels as well. Now, in terms of baroreceptor reflex, there's two major areas that you're going to find baroreceptors. One is going to be right here. It's going to be seen in the aortic arch. And then the other area is going to be within your carotids. Now, you don't ever want to do this to a patient that has arthrosclerosis of the carotid arteries, but sometimes if somebody's like having a panic attack or they're having anxiety, or for whatever reason their heart rate is like super accelerated, one thing you could do, they call it a carotid massage, where you just basically rub their carotid arteries and you're inducing pressure in those carotid arteries so that you can induce the baroreceptor reflex. When you do that, when the baroreceptors start to get stimulated, they're going to reflexively reduce sympathetic activation. So by reducing sympathetic activation and then inducing parasympathetic activation, they're going to be reducing cardiac output, stroke volume, reducing heart rate, and then parasympathetic reaction also reduces heart rate by releasing acetylcholine on the muscarinic receptors of the heart. So that's one thing to keep in mind in terms of the baroreflex. And here's a little summary of what that looks like. You have here in your medulla oblongata, as well as in your spinal cord, you're going to have different sides of the baroreceptor reflex. In the medulla oblongata, you're going to have a lot of your parasympathetic activation taking place, which is going to be moderated mostly by cranial nerve 10, your vagus nerve. And if your vagus nerve gets stimulated to begin releasing, for instance, acetylcholine at your SA node, acetylcholine binds to muscarinic receptors. That's going to slow down the heart rate. And so if you have too much baroreceptor activation, that means that your blood pressure is way too high, then your medulla oblongata is going to be coming into play to actually induce a parasympathetic reaction, to reduce the heart rate and reduce contractility. On the other side of the coin, you have the sympathetic trunk, and that's going to be increasing your cardiac output. When your sympathetic system gets activated, then you're going to have an increase in cardiac output, increased contractility, increased stroke volume, which thereby increases your mean arterial pressure. So here's another diagram of what that looks like. Baroreceptor, just keep in mind, it has all to do with blood pressure. So high or low blood pressure. If your blood pressure is too high, that means your baroreceptor reflex gets activated. It's going to decrease sympathetic tone. It's going to increase parasympathetic activation. And it's going to help in either vasodilation or vasoconstriction, depending on what your goal is. If you have too high blood pressure, you're going to start vasodilating. That's going to be the parasympathetic response. If your blood pressure is too high, you're going to bring down your heart rate and cardiac output. And then the opposite is true. So let's talk a little bit about chemoreflex. So this is going to be moderated by both carbon dioxide and oxygen levels, as well as the pH. The chemoreceptors, there's going to be a few. Aortic arch, kind of similar to the baroreceptors. Subclavian arteries are also going to have chemoreceptors, and then the external carotids. So if you notice, you'll see baroreceptors and chemoreceptors in the carotid arteries. You'll see both of those also in the aortic arch. The only major difference is that in the subclavian arteries, you'll also see those chemoreceptors. Moving on. So this is what's going on with chemoreceptors. If you have too little oxygen, that's going to stimulate your chemoreceptors. So if you're hypoxic, your chemoreceptors get stimulated. If you have too high of carbon dioxide, also is going to stimulate your chemoreceptors. Then if your pH is too low, which means that you have, actually, let me ask you guys, what does that mean if your pH is too low regarding carbon dioxide and oxygen? What lowers your pH? Huh? Acid, yeah. When your pH is low, that means you're acidotic. So what causes acidosis when it comes to those? Carbon dioxide, yeah. So carbon dioxide accumulation, that's going to result in acidosis. So I always like to go back to my opioid overdose patient, right? So a patient is overdosing on opioids. The major way that they die is when they undergo respiratory depression. That's usually what happens. And if you undergo respiratory depression, you're not breathing out as much carbon dioxide. So if you're not breathing out as much carbon dioxide as you should, that carbon dioxide accumulates, and then all of a sudden you start becoming acidotic. Now, on the other hand, if you're like really nervous or you're having a panic attack and you start like hyperventilating, you're breathing really rapidly, you're expelling more carbon dioxide, and then now you're going to start becoming more basic. So now you start becoming more alkalotic. So the opposite is true. But in terms of chemoreceptors, they're specifically going to be reacting to low pH. Low pH indicating that the patient has too much carbon dioxide in their blood. So what's going to happen as a reaction? You're going to have increased respiratory rate, you're going to have increased heart rate, and you're going to have increased blood pressure as a reaction. So these are the major things over here. You have increased carbon dioxide levels, decreased pH, um, decreased O2 levels. That's going to stimulate the chemoreceptor reflex. And that's all going to be moderated by the medulla oblongata as well as the cardiovascular system. So in the medulla oblongata, you're going to help increase your respiration, right? So you can breathe out that carbon dioxide, breathe in more oxygen, and then your cardiovascular response, you're going to start undergoing vasoconstriction. You're going to start pumping out blood as much as possible so that you can oxygenate that blood. Now, let's talk about the renin-angiotensin-aldosterone system. So the reason why I started with the kidney is because that's kind of where it starts. Now, if you have, so back here with the baroreceptors, we're talking about too much pressure, right? You have way too much pressure. Your baroreceptor reflex is going to try to bring your blood pressure down. Okay, so it's going to help vasodilate. It's going to help reduce your heart rate and cardiac output. On the opposite end of the spectrum, you have the renin-angiotensin-aldosterone system. Okay, and it's going to start with renin, and renin is going to be released by the kidneys. Okay, so think renal renin. This is the glomerulus, and that's where you have urine getting filtered out, right? And so as part of your collecting ducts, you have proximal and you have distal convoluted tubules. The distal convoluted tubule right here, that's going to be running directly adjacent to your afferent arterioles. Afferent and efferent. Afferent is the ones coming in, efferent are the ones exiting. So if the afferent arterioles are pumping too low, that means you have reduced blood volume, you have low blood pressure. That's going to actually start triggering the juxtaglomerular cells to start helping to activate the renin-angiotensin-aldosterone system. So in other words, low blood volume or just low blood pressure in general is going to activate the juxtaglomerular cells. Once the juxtaglomerular cells get activated, then you're going to start getting release of renin. That's going to be the very first step. Actually, the very first step really is going to be decreased blood volume. Decreased blood volume and then decreased blood pressure. Then once that gets released, once you start getting renin release, renin basically kind of acts as a catalyst to allow angiotensinogen from the liver to get turned into angiotensin 1. Okay? Angiotensin 1 doesn't really do much. It needs to be converted to angiotensin 2. The way that it does that, it goes to the lungs, and in the lungs you're going to see ACE. Which is angiotensin converting enzyme. So you need ACE in order for you to get angiotensin 2. Once you get release of angiotensin 2, or the conversion of angiotensin 2, angiotensin 2 is a really potent vasoconstrictor. So think you have your blood pressure's low, right? You have low blood volume. What do you want to do? You want to try to vasoconstrict. You want to try to maintain mean arterial pressure. So you have vasoconstriction, but you also have a bunch of other things happening in consequence too. So you have vasoconstriction, right? So that's going to help to increase your afterload. That's going to help to increase your mean arterial pressure. You're also going to see stimulation of the adrenal cortex. The adrenal cortex is going to be releasing aldosterone, okay? So aldosterone, just think of aldosterone as being a way to help reabsorb sodium back into your body, bless you. And that's going to be taking place in your renal system, right? So your kidneys are going to start reabsorbing sodium. Water follows solutes, and all of a sudden you start increasing your fluid volume. So the major thing that you're seeing is an increase in sodium. You're also going to be seeing secretion of potassium as well as hydrogen into the urine as a consequence. Once you start seeing increase in blood volume, then you start stabilizing your blood pressure, and now you're back to a normal mean arterial pressure. So here's another flow chart of what that looks like. If you have low blood volume, right? Maybe you're dehydrated, okay? Or maybe you have a hemorrhage and you're bleeding out a little bit. Low blood volume or low blood pressure, it's going to stimulate this system. Also, hyponatremia can also stimulate this system because of aldosterone, right? Aldosterone is going to be the major hormone that allows for reabsorption of sodium back into the body. And then the major goal of renin, of course, is going to be to increase angiotensin 2. That's going to be the major one. And then antidiuretic hormone is also going to be released as well, which is also known as vasopressin. So let's go through that system again. Kidneys release renin at the juxtaglomerular cells. Renin is going to help convert angiotensinogen from the liver into angiotensin 1. Angiotensin 1 is going to arrive at the lungs. At the lungs is where you find angiotensin converting enzyme, or ACE. And then when ACE converts angiotensin 1 into angiotensin 2, that's when you see that downstream effect of, or that cascade effect of the release of aldosterone, a release of antidiuretic hormone. You also do see increase in thirst. So the person who, our patient, starts getting thirsty, starts consuming more water. The whole goal of this is just to increase your fluid volume. That's the major goal in this. So yeah, I highlighted kidneys there because that's going to be the first point of release. Bless you. And then there's one thing, side comment that I want to make here. You guys ever heard of ACE inhibitors as a class of drug? Cool. ACE inhibitors are a very common drug used to help bring down the blood pressure. Now, if you follow this system, ACE inhibitors, that's going to block angiotensin converting enzyme right here. So that's what the ACE inhibitor is doing. ACE inhibitors, when you give a patient ACE inhibitor, it helps to prevent the formation of angiotensin 2. Angiotensin 2, as I mentioned, that's a very powerful vasoconstrictor. If you block ACE with an ACE inhibitor, then you're not going to vasoconstrict. You're going to vasodilate, and that helps to regulate patients that have hypertension. So it's a very commonly used class of hypertension drugs. So here's the summary of that. So kidneys releasing renin. That's going to trigger the renin, angiotensin, aldosterone system. Angiotensin 2, that's going to be the major player. That's going to be what helps to vasoconstrict. Also helps to release antidiuretic hormone. Where is that going to be released from? Where is ADH released from? Which part of the pituitary? Posterior pituitary. Excellent. And then aldosterone. Where's aldosterone released from? Awesome. And let's see, aldosterone absorbing sodium, and then you have increase in fluid volume, and an antidiuretic hormone. You're basically going to prevent diuresis. All right, moving on. All right, so another way that your heart helps to reduce your blood pressure, if you have too much fluid volume or if your blood pressure is too high, then that's going to stimulate atrial natriuretic peptide as well as brain-derived natriuretic peptide, B type. It's brain-derived natriuretic peptide. Atrial natriuretic peptide is from the atrium. BNP is going to be from the ventricles. And so basically what those do, they're going to help maintain sodium volume. So you're going to increase your urine volume. You're going to try to decrease the person's blood pressure with the release of these. And you're going to excrete sodium. So it's going to be the opposite of the renin, angiotensin, aldosterone system. You're going, instead of trying to increase reabsorption of sodium, you're going to try to release as much sodium as possible so that you can increase fluid volume and decrease your blood volume, blood pressure. And so increase in blood pressure, blood volume, that's going to stimulate the release of both of these, AMP and BNP from the heart. And then this is going to be the consequence. You have sodium loss from the kidneys, water follows solutes, right? So you're going to have a higher volume of urine. It's actually going to decrease the patient's thirst, or the individual's thirst. And you're going to inhibit antidiuretic hormone, right? So antidiuretic hormone, you'd prevent urination. You want to increase urination. So you're going to inhibit ADH. You're going to inhibit aldosterone. You're also going to see an inhibition of epinephrine, norepinephrine, okay? Because those are all going to be trying to increase your blood pressure. You want to decrease your blood pressure. And then you also see dilation at the level of the vessels. Right on. So that's it for chapter 20. Do you guys have any questions, or do you guys just want to get into the questions, the quizzes questions? Nobody has any questions? I heard a lot of you guys sneezing today. Are you guys allergic to this stuff or what? I know I am sometimes. Anyways, yeah, don't do what this meme says here. Don't pull those out. My wife showed this to me yesterday. I thought it was kind of cute. All right, so let's log in. Well, I counted 53. Once 53 of you all log in, then we can start. Anybody having a hard time logging in? All right, I'm going to go ahead and hit start. If you couldn't log in, just give me your name. All right. Dang, that's quite a spread. Okay, so let's go back and look at the slide regarding BNP. So this is the slide regarding BNP, okay? Make sure you know everything that's going on up there. This area right here is very important. So when you have the release of ANP and BNP, okay, you're not only going to reduce the release of epinephrine, norepinephrine, you're also going to inhibit antidiuretic hormone, but aldosterone is going to be one of the most important things as a consequence of ANP and BNP. Bless you. So with aldosterone, you're going to block aldosterone so you can try to reduce the amount of sodium being reabsorbed, right? You want to excrete as much sodium as possible. The goal is to reduce the blood pressure, okay? So the way that you do that, let's go back to the question. The best way to do that is to decrease blood volume. You're going to inhibit aldosterone. You don't want aldosterone because aldosterone is going to increase your sodium levels. If you increase your sodium levels, you're thereby going to increase your fluid retention as well. Does that make sense, guys? Yep. Yeah. Hmm. Dang. Let's see if you guys got incorrect. All right, let's look at the chart that talks about cross-sectional area. That's the key word, is the area. I think it's way in the beginning here. Where the heck is it? There it is. All right. So make sure you know, not diameter. Okay, the diameter of the capillaries, yes, those are the smallest. They're the smallest diameter. They're the smallest radius of all the vessels. In terms of total area, you got a lot of surface area for your capillaries. Does that make sense? Because you have to have exchange of gases, waste, nutrients. That all happens at the level of the capillaries. They're really important. Just think about them being as important. You need to increase that surface area. That's the whole purpose. Okay, so you have lots of capillary beds. So in terms of cross-sectional area, that's going to be the widest. It's going to be the largest. And then blood pressure, make sure you know that blood pressure is the further you get away from the heart in terms of distance from the arterial system, the lower the blood pressure is going to be. Are you guys good on that? It wasn't really a trick question. I think you just had to cross-section versus diameter. I think that was the thing that threw you guys off. Sweet, good, awesome. So yeah, lipid-soluble substances, they go right directly through a endothelial cell. So they don't need any sort of special pores or transfer proteins. So like carbon dioxide, oxygen, steroids, all that. Those are all lipid-soluble. They cross right through. So good job on that. And what's the opposite of diffusion? All right, good. So most of you guys got it right. Diffusion, simple, right? You're moving from high uh, pressure, high concentration to low pressure, low concentration. Osmosis is a little bit different. You're going to go from low concentration to high concentration, and that's going to be the movement of fluids, aka water. Bless you. Good. Most of you guys got it correct. Yeah, that's most of you. So capillary osmotic pressure. That's going to be the most important thing that determines whether or not fluids come back into the capillaries. Okay? What's that going to be determined by? What's why is like fluids? Why would fluids want to enter back into the blood? Huh? Which would be due to what specifically? Huh? Sodium? No, not quite. Something else. Something that's made by the liver. Albumin, yeah. So albumin, that's going to be what's really important to help determine whether or not fluid's going to want to enter back into the capillaries. So that's going to be capillary osmotic pressure. For those of you who are thinking interstitial fluid hydrostatic pressure, what made you think that? If you wanted to volunteer your thought process, don't be embarrassed. It's not, it's an honest mistake. Is the pressure going to be higher in the capillaries in terms of blood pressure than it is in the interstitial fluids? Yeah, it's going to be way higher. So in other words, interstitial fluid hydrostatic pressure, that's not going to be higher in the interstitial space. That's going to be much, bless you, it's going to be much higher within the actual blood vessel itself. Okay, it's going to be low outside of the blood vessel. That's hydrostatic pressure. Osmotic pressure, that's different. Osmotic pressure, you want to draw fluids back into the blood vessel, so the osmotic pressure is going to be really high, or it should be really high in the blood vessel. If you're protein deficient, if you're starving, then that osmotic pressure, that capillary osmotic pressure is going to be much lower. It's going to be higher in the interstitial space. That's quite a spread. Okay, so your blood pressure, it's really high. Okay. Maybe your blood vessels have atherosclerosis, or maybe your blood pressure is high because you're out on a jog. Okay, so you're jogging, you're exercising, you're running away from that lion. That's going to increase your hydrostatic pressure. That's going to increase the pressure within the vessels, within the capillaries as well. Okay. That's not going to change the capillary osmotic pressure at all. When your blood pressure is high, the amount of albumin, so think about it as in terms of albumin, okay? The amount of albumin is not going to change. It's going to be the same. If you had liver damage, that's a different story. Your albumin levels would change, okay? Or if you're starving, if you don't have enough protein in your diet. And then again, the interstitial fluid, hydrostatic pressure, that's not going to change when you have hypertension. All right, next. Bless you. I'm going to start passing out some antihistamines in here. Yes, I knew this was going to be a confusing one. That's why I wrote it. Awesome. So, albumin. You don't have, okay, you have liver failure, right? And now you don't produce enough albumin. Okay, what's going to happen? What's going to happen to your capillary, what's going to happen to your capillary osmotic pressure? Up or down? Down. Yeah, cool. So it goes down. Now, what happens to your interstitial fluid osmotic pressure in relation to the capillary osmotic pressure? It's going to be relatively higher now than it was previously. If you did it relatively speaking, if you did a ratio, it would change. So, yeah, don't get confused. If you have liver failure, just because you see capillary osmotic pressure, don't think albumin right away. Make sure that you understand the difference, okay? So that would be reduced albumin within your vessels. Then the solutes and all the proteins that are within that interstitial fluid interstitial space, that's going to be relatively higher now. And then that's why you get the edema. That's why you get ascites. That's why you get edema when you have a liver failure. Good. And I put mostly in there because theoretically, if you had nitrous oxide, you would be able to vasodilate a little bit, which might increase your preload. That might increase the amount of blood coming back to the heart, which would thereby increase your, which volume? End systolic volume and diastolic volume. Which one would that increase? Someone say end systolic volume? Diastolic volume, right? Because end diastolic volume, that's the most amount of blood that you get into your heart before the contraction. So you would potentially increase the amount of blood going to your heart. So it might theoretically increase your cardiac output because of that. You would get a larger end diastolic volume, and then your stroke end systolic volume would be the same. Then you might have a greater amount of blood getting pumped out. So it could potentially increase stroke volume, increase cardiac output. But mostly it's going to cause vasodilation. Okay? Histamine and nitric oxide do not cause vasoconstriction. Okay? Just think about nitric oxide as being a substance that's used, especially for patients with like angina, and that would cause vasodilation to help to relieve the symptoms of angina. It would cause vasodilation of those coronary vessels. Do a couple more. Bless you. Good. Excellent. I'm glad you guys got that right. So yeah, we're not going to see much in terms of high pH. If you had high pH, that means that your carbon dioxide levels are good, are stabilized. If you have low pH, that means you have too much carbon dioxide, and then you're going to want to start breathing more rapidly so you can expel as much carbon dioxide as possible and increase oxygen levels. Right on. Two more. Awesome. Good. Yeah. So renin. Renin gets released at the juxtaglomerular cells, and then that's as a result of decreased blood volume. When the blood pressure is low, blood volume is low, then you want to try to stimulate increase in blood volume. So you increase angiotensin 2. You also increase aldosterone. You try to reduce diuresis. Okay, so you release antidiuretic hormone. So awesome. Most of you guys got that right. Let's do one more. And we'll get into chapter 21, a little bit of it. Excellent. Good. So the first one in that series, well, the first one's renin. Then renin helps to convert angiotensinogen to angiotensin 1. Then what enzyme converts angiotensin 1 to angiotensin 2? ACE. Good. So angiotensin converting enzyme. And then you also get the release of aldosterone too. But angiotensin 2 is going to be the one that helps to vasoconstrict. All right. Good job, guys. Let's get into a little bit of chapter 21. And by a little bit, we'll go maybe like 10 minutes or so. Is that cool with you guys? You said no. Well, you want to go for like another 20 minutes? Is that what you want? No. All right, let's do this. Anyways, any questions on chapter 20? It's a little bit of a slog. The main things I want you to keep in mind would be all of this. Let's see, let me show you exactly the kind of things I want you to focus on for chapter 20. Where's it at? There's that chart. This chart right here. Like, focus on all this, all these different things that have effects on mean arterial pressure. Okay, if you're able to conceptualize this chart pretty well, and then go through like some of these different practice questions and whatnot, then you should be pretty good when it comes to hemodynamics. And this stuff is really, I know it's a little bit of a snooze fest talking about hemodynamics. It's not really one of my favorite topics. I'd rather talk about other things, but it is really important because when you guys get into clinical medicine, when you start seeing patients, you'll start realizing that your bread and butter in medicine is really like blood pressure, especially in primary care. You're going to see lots of patients with high blood pressure, hypertension. I mean, that's one of the things that's, you're going to be dealing with all the time. It's one of your 4 vital signs too, right? So high blood pressure is really important. It affects your whole entire body. Renal failure, strokes, heart attacks, just atherosclerosis, all of that is going to be affected by blood pressure. So when we talk about hemodynamics, I know it's kind of boring, but it's very important. You guys definitely need to understand all those different systems and how they come into play. Yeah, that's all I have to say about that. So let's talk about the lymphatic system. So we kind of briefly talked about the lymphatic system a moment ago, right? 10% of what gets filtered out from your capillary beds is going to wind up in the interstitial space, right? So in the interstitial space, you get 10% accumulation of fluids. Those fluids need to go somewhere, and then they go into the lymphatic system. Now, there's a lot of different conditions that might interfere with the lymphatic system. And if you do get those types of conditions, they may result in things like lymphedema. Lymphedema is not good. I saw a lot of patients that had lymphedema. As you can tell from this image, first of all, very uncomfortable, right? You have a ton of fluid accumulating in appendages, your limbs, especially in your lower extremities. Notice the skin. If you Google pictures of severe lymphedema, some of those pictures are really hard to look at. It's awful. Like if you have too much fluid and too little circulation taking place in your lower extremities especially, it can really cause a lot of damage to the skin. So it's pretty scary stuff. As I mentioned earlier with radical mastectomies, women who have breast cancer, especially if they're BRCA1 or BRCA2 positive, those patients often require bilateral radical mastectomies. They have to get their breasts completely removed, not just the breast tissue, but also lymph nodes. There's axillary lymph nodes that drain the breast. Those axillary lymph nodes also drain the upper extremities. And so when a person gets a radical mastectomy, depending on how many of the lymph nodes get removed, they start getting this on their arms as well. And so it's pretty serious stuff. Here's another image of really, really bad lymphedema. Not very fun. So we're not going to talk about the innate and adaptive immune system for this portion. We're going to talk about it in the next portion. We're going to go into a lot of detail about B cells, T cells, and how those work. Antigens, and how antigens, which are antibody generators, create or stimulate B cells to create antibodies. So we're going to talk about that next in the next section of chapter 1. But for this section, it's going to be sort of piggybacking off of chapter 20. We're going to talk about like filtration and all that. And then we're just going to talk about basically what the lymphatic system does. So the lymphatic system, as I mentioned already, 10% of fluids are going to be filtered out of the capillary beds, right? Not everything is going to get reabsorbed into the capillaries. There's going to be more fluids filtered out. Those fluids need to go somewhere, and they're going to go into the lymphatic system. Any sort of interference with the lymphatic system is going to cause lymphadenopathies, lymphedema, swelling, right? The lymphatic system plays a huge role in your immune system, right? So a lot of your lymphatic tissues are going to have immune system functions. So we're going to talk a little bit about, for instance, like the MALTs, the mucosal associated lymphatic tissues. That's where you see like dendritic cells that pull antigens from the environment in your GI tract, so that if anything pathogenic gets detected, it can get presented to T cells, so that T cells can start undergoing a immunological reaction to whatever it is that's in your GI that might be problematic. So we're going to talk about how the immune system is, the lymphatic system is heavily implicated in the immune reactions. And then lipid absorption is also going to be taking place in the lacteals. You're going to find those in your GI tract. Those are going to be found within your mucosal membranes of the intestines. So this is a similar image that we saw already in chapter 20. So you'll see that you'll have filtration of nutrients, oxygen, things like that, depending on where you're at. So let's see, filtration of oxygen into your tissues and your peripheral tissues. You'd have reabsorption of oxygen in your lungs. And then your pressure starts decreasing. The capillary hydrostatic pressure starts decreasing. And then at that point, when you get towards closer to the venules, that's when capillary osmotic pressure basically takes over. So here are a couple images of what we've been talking about already in terms of diffusion versus osmosis. Diffusion is just high volume moving towards low volume, nothing too crazy. Osmosis, that's where you get that osmotic pressure, where you have fluids following solutes. Okay, so you think capillary hydrostatic pressure, you're thinking diffusion over here, and then capillary osmotic pressure, you're thinking reabsorption of fluids. That's going to be heavily based upon the levels of albumin in the patient's body. Move on from this. So hydrostatic pressure, that's what you see in your capillaries, and then the osmotic pressure. As I mentioned, the textbook talks about colloid pressure. It's like the same thing. You guys know what a colloid is? Milk. Have you guys heard like milk is a colloid? You just have like all these little particulates basically freely suspended within a solution. That's what colloids are. It's just like a bunch of solutes that are within a solution, especially when it comes to like proteins. That's basically what albumin is. Albumin acts in a similar way. So when you think osmotic, you're thinking colloid pressure. Think the same thing, okay? But we're going to refer to it as osmotic pressure. So let's recap chapter 20. On the arterial side, you have a greater amount of filtration. On the venous side, then you have a greater amount of reabsorption. Filtration, heavily reliant on the hydrostatic pressure. Reabsorption, heavily reliant on osmotic pressure. Moving forward. We already basically talked about all this. Moving forward. So net filtration. So think 10%. It's about 10%. It could be up to 15%. And then fluid would accumulate into the interstitial space. It gets reabsorbed into the lymphatic capillaries. And those lymphatic capillaries are going to deliver lymph to your lymph nodes. In your lymph nodes, we're going to talk about what you find in your lymph nodes. You'll find a lot of like B cells and T cells within your lymph nodes. That lymphatic tissue basically gets filtered out so that you can see if there's any sort of like disease-causing agents within the lymphatic system. We talked about all that. About that already. All right, so here's your capillary. So this would be like a cross-section of one of those capillary beds plus the lymphatic capillaries. As blood is moving through the capillaries, it's going to be filtered out into your interstitial space. And you could think of your interstitial space as being a loose type of connective tissue. Okay, so fluids are able to just freely move into those areas without any issue. And then if you have too much fluid in those areas, then they're going to be drained into your lymphatic capillaries. So we talked a little bit about edema already, but edema, there's several different stages of edema. The biggest or the more severe type of edema would be pitting edema. That's when you press down on the skin and then you let go and you see how long that edema lasts. So you see how long the pit stays in place before it goes back to normal. And that's going to be especially severe in patients that have right-sided heart failure, congested heart failure. And then in terms of other causes of edema, there's quite a few, right? We talked already about poor venous return, which would be associated with heart failure. Kidney failure can also result in edema. So if you're not able to excrete fluids, you're going to have a buildup of fluids. Okay, so if you have a buildup of fluids, that's going to basically cause not only hypertension, but it's also going to cause edema as well. Histamine, we already talked about how that increases vascular permeability. If you have hypoproteinemia, that's going to be where you have reduced oncotic pressure, right? So you have reduced capillary osmotic pressure, same thing. That's going to result in things like kwashiorkor. So that's this image over here. Those are those kids that are unfortunately suffering from starvation. They don't have enough protein in their diets. They're not able to develop and produce enough albumin to be able to maintain that capillary osmotic pressure. And then obstruction is going to be another serious cause, right? There's you can get obstruction from injury. You can have obstruction from surgical removal of lymph nodes. There's also certain parasites that can obstruct your lymphatic vessels. Okay, and then burns. Burns are also going to result in a fluid shift. If you work in a burn unit in the future, that's one of the biggest concerns with patients that get severe burns. They'll get what they call a fluid shift. You'll have fluids basically leaving the vascular system and entering into the interstitial space. So that's one big concern with burns. In terms of treatment for lymphedema, you can do exercise. We talked about how when you flex your skeletal muscles, that helps to basically allow blood in the venous system to move. Right? Same thing with lymph. The more you move, the more you're able to get the lymphatic system circulating properly. Some people have to wear compression garments, especially in the lower extremities, if they have really bad congestive heart failure. You could use these pneumatic compressions, which she looks like she's maybe having a good time, I guess. It doesn't look like a really good time. But lymph massages, if you ever work in oncology and you have those patients that had radical mastectomies, that's going to be one of the ways that they treat it. It's just literally they go in and just massage the lymph out of those limbs. So not very fun. And you can also use water pills, right? So diuretics. You can use Lasix to try to treat that, so you increase the amount of urine production and urine release. So here's an image of what you might see with a patient that has a radical mastectomy. This is just one article out of many. This is an article that came out a couple years ago. But they were talking about different types of treatments. A lot of the same types of ones that we just talked about here. So like manual lymphatic drainage, exercise, also weight control. Those patients you might also want to have reduce the amount of sodium in their diet, right? So you don't have as much fluid accumulation. Skincare. As you saw in those earlier images that I showed you, and if you Google search images of lymphedema, you'll notice that oftentimes those patients have very fragile skin. That skin is extremely prone to damage. My grandmother, she had really bad hypertension, and so she had really severe pitting edema, and she would get these ulcerations in her leg that wouldn't heal for months, up to years. She had an ulcer once that was I'd say about 5 centimeters wide in diameter. And she would have to get it treated every single day by nurses because of her hypertension. She had congestive heart failure. So skincare is really important with patients that have accumulation of fluids where they basically don't belong. So I promised 10 minutes. I went 13 minutes. So I apologize for that. Have a wonderful weekend, guys, and I'll see you all next week. Take care.